Greetings, I'm Jennifer Kennedy, the lead for compliance and quality at CHAP, and welcome to CHAPcast. So today we're going to hash through some of the content, or give you the highlights rather, of the calendar year 2026 home health payment update rule, but only for the home health content for this particular podcast. And I am joined by my compadre, my colleague, my longtime friend, Kim Skehan, and Kim and I are going to hopefully hit some of the highlights for you so that you understand what the requirements are in this final rule. Kim, how are you doing today?
You know, it's been a whirlwind for sure, for certainly us, but as well as for providers. I mean, as we go through the home health components of the home health final rule, there certainly are areas that specifically related to payment that providers need to focus on. We, as also an AO, also have the responsibility for DME, the DME changes as well as the AO changes. So when we follow up with the additional podcast on that component of the final rule, I think that also will be extremely informative as well. So it's been a bit busy, but we're all in it together.
We're in it together, and you're right. We'll handle the DME in a separate podcast. This year, was kind of unusual because we had. Dare I use the respite, the hospice term respite, meaning that, the government was shut down and many CMS staff were on furlough. So nothing happened. And the time that we would usually be looking for this final rule to post, end of October, beginning of November, it didn't happen. And, here we are pushing Thanksgiving essentially and having a rule come out that Friday after Thanksgiving. So we have basically a month. We've lost a month as home health providers in reading the rule, understanding the rule, and unfortunately, that implementation date for the provisions for home health is January 1, 2026. So you're coming into this, a year, oh my gosh, a month behind the eight ball, with not a lot of time to implement whatever you need to implement. And I think, Kim, let's start out with, why should listeners be paying attention to this particular topic of a final rule?
Sure. I think, first of all, any final rule provider should be looking at, even if it is not your service line. So for example, this is the home health final rule. And as you can tell, DME and AO oversight was embedded in this final rule. We've seen the same with home health and hospice, right? And physician final rules. So, it really is important for organizations to keep track of any of these proposed rules that are coming out to determine applicable areas. And that's also where the state and national associations, the Alliance, for example, that really do a great job in terms of culling through them, but providers really are responsible for knowing. So the final rule provides the update to the upcoming calendar year payment for a home health agency, but also serves as a vehicle for introducing those new regulations or changes. And in the final rule is based on the proposed rule and taking into consideration where CMS feels it's appropriate, the comments that are submitted from providers, or from the industry during the comment period, which, if I'm correct, Jennifer, was, with all the comments, was the final rule around 762 or so pages.
762, my friend. Now, what wine would we pair with that? I'm thinking a very heavy red.
Yeah, I'm with you
because it was a very heavy rule in order to read that one through.
Absolutely. So for this final rule, there is the rate cut. There is still a rate cut, much lower than proposed, and overall minor changes to other payment, components such as LUPA thresholds, case mix weights, and value-based purchasing, and then also some regulatory changes that really are essentially unchanged from the proposed rule. So I think I think just going through them, I think will be extremely important. I would also say that there are other resources for expertise, such as the National Alliance for Care at Home, many expert consultants in the industry that also are providing and EMRs, I believe, and other state and national associations providing some additional information as well. So from my perspective, we can speak to the components of the rule, but each organization needs to evaluate internally themselves. How does the final rule impact you as a provider, and what other resources can I utilize to be able to really ensure appropriate implementation or analysis?
Yeah, definitely, and I agree with your shout out to the Alliance, because I think they do a really great job in the payment area. And while 1.3% is better than that proposed 6.4%, it's still a cut. And you're right, providers need to figure out how they're going to operate in calendar year 2026 on a 1.3% deficit. Now, remember, sequestration is still in place as well. So 2% comes right off every claim as soon as it's submitted. So, we're really talking about a 3.3% when all is said and done.
Yep.
So I know that there were some other changes or finalizations of language from proposed to final that are outside of that payment area. And even though it's kind of in the coverage regulations, Kim, that face-to-face encounter policy, CMS did finalize that language, and I'm hoping you could walk our listeners through that.
Sure, absolutely. So CMS did finalize the change, or really codify the change to the face-to-face regulation to allow physicians, in addition to nurse practitioners, CNSs, and PAs, to perform the face-to-face encounter, regardless of whether they are the certifying practitioner or whether they cared for the patient in the acute or post-acute facility from which the patient was directly admitted to home health and who is different from the certifying practitioner. This is important because from a payment perspective and denial perspective, over the years there had been, denials, and I think occasionally still denials, if the practitioner that has signed the face-to-face was either, not, was not that certifying practitioner. So that took a long time for organizations to get processes in place, and for CMS and the MACs to get that clarified. This is finalizing that requirement. I do want to shout out to Katie Weary at the Alliance, because when she did her provision, she did remind everyone of the original intent of the face-to-face encounter, which is determining eligibility for the home health benefit. And one of the comments or one of the requirements that is in the final rule, and it's also in the face-to-face requirement, is that the physician or allowed practitioner conducting the face-to-face encounter is the most knowledgeable practitioner and has firsthand information of the patient's current clinical condition, and that all other face-to-face encounter and certification requirements remain in place and are conditions of payment. Why this is important is because even though the language in the final rule says regardless of whether they're the certifying practitioner or they cared for the patient, CMS at some point will be looking to likely to determine if the practitioner signing that face-to-face encounter did have contact, not current knowledgeable relationship, with that particular patient. So not sure how that will play out, but, just keeping that in mind when organizations are receiving and obtaining the face-to-face encounter.
Yeah, I think everything could be up for grabs when you have a change in regulation. It could be an edit that the MAC sets. It could be a target for any of the CMS related auditors, SMRCs and UPICs and RACs, all of those things. I think once we see changes like this, those could be actual targets, as we move forward to look at compliance and possibly deny claims if it's in the coverage area.
Absolutely. Jennifer, do you want to? So that's the face-to-face encounter. I do want to. I'll mention this, and then if you don't mind, to hear more about the home health quality reporting and value-based purchasing, changes specifically as it relates to quality reporting. I think that will be important. But I do want to just mention regarding the all-payer requirement for the alignment of the COPs with the OASIS all-payer submission requirements and the language to reflect all payers. So from patient to beneficiary, this is a technical requirement, right, that needs to change to align the COP with the all-payer requirement. But I do want to take this time to just remind everybody of that requirement. If you are a Medicare certified home health agency, you must submit an OASIS, complete OASIS for or complete OASIS for all payers for those patients receiving services unless they are otherwise exempt. In other words, under 18, receiving maternity care only or personal care services only. So that's been a source of confusion, I think, for some organizations that may have private duty, for example, under their home health umbrella. So you really need to make sure that you're clear on those processes and that, the data collection requirement and submission. Jennifer, what is our plan at CHAP for updates to our standards related to this area?
You're just reading my mind, Kim. And thank you for bringing that all-payer, all-OASIS point to the table. So what we usually do and what we're doing right now is once a rule is finalized, we go ahead and look at our standards to see where we need to do the updates. And that's what we're completing as we speak. And before we can put them out to our home health providers, our CHAP providers, they have to go to CMS to be reviewed and approved. And then once they're approved, then we can update our providers with that newest copy of the standards. So a little bit of time that it takes in order for us to make sure that we're doing it in the compliant way. But please be looking out in the new year for the updated standards as it relates to this final rule.
No, that's great, Jennifer. Do you want to talk just a little bit, going back to the quality reporting, any key points related to quality reporting and CAHPS as it relates to VBP?
Yeah, I'll just go ahead and point out a few highlights. CMS did finalize a few things in this area. They are removing the COVID-19 vaccine measure out from the OASIS as a data element. They're also removing 4 assessment items in that standardized assessment. And the 4 are the living situation item, 2 food items, and 1 utilities item. So CMS is also revising their home health CAHPS survey. And that new survey will implement beginning April 2026 in that sample month. And that revised survey also removes several items in the multi-item specific care issues measure. And 3 of the items used in the specific care issues measure will remain in the HHCAHPS survey instrument. So they're doing a little bit of shuffling around. Also, the rule is not that this is, well, I guess it's technically attached to quality, but if you find that you get the dreaded letter that says you're not compliant and you're eligible for a 2% reduction in a payment rate because you didn't submit your quality information, CMS did update their reconsideration policy so that it's essentially codified for any kind of extraordinary circumstance. So if you had a flood, fire, tornado, hurricane that interrupted your ability to submit timely quality information, and you got the letter and you wanted to appeal it or send in a reconsideration, you would have to just outline the circumstances, time frame, etc. So CMS did update that as well. And you did talk about the all-payer. There were some updates to the home health value-based purchasing model beginning April 2026. I mentioned that we will have those changes to the HHCAHPS. CMS will remove the care of patients, communications between providers and patients, and specific care issues. They also finalized the addition of 4 measures to the applicable measure set. This includes 3 OASIS-based measures related to bathing and dressing, and 1 claims-based measure, which is the Medicare spending per beneficiary for post-acute care setting measure. Wow, that's a big, long mouthful there. But the removal of these data elements, Kim, is associated with the HHQRP assessment as of April 1, 2026.
Yeah, thanks, Jennifer. And again, any changes to the value-based purchasing model, including these measures, also will impact an organization's reimbursement or the impact of value-based purchasing. So as well as any other data changes that also are included. So value-based purchasing, both the CAHPS changes certainly as well as quality reporting changes, potentially they impact our reporting and quality, but also payment. Once they are, integrated into the value-based purchasing model.
Yeah, and I think it's fair to say, Kim, that we've seen, even though we're not talking about the DME part today, there is the overall theme and tone in that rule about combating fraud and abuse. And we still have fraud and abuse happening in home health as well as DME, but CMS is really serious. They have a war, what they call their fraud and abuse war room up at CMS in Baltimore that is looking at all provider types for decreasing fraud and abuse. So it's something that CMS is serious about, and we're going to keep seeing this type of language infused in these provider rules because that is one of their initiatives up at CMS for this fiscal year.
Yes, absolutely. And even in this final rule, there are some changes or updates to Medicare provider enrollment. So, and that just, again, speaks to that focus of anti-fraud, not just in DME or hospice, or other settings. It's definitely across all settings that CMS is, taking notice and implementing, I think, changes and likely aligning some of these enrollment requirements across settings whenever they can. And most definitely, we have seen, and I think the industry has seen, a really significant focus on initials or organizations that are starting home health or hospice, as well as child change of ownership, but also if you have to conduct revalidation. So it's
Right.
extremely important that agencies stay attuned to ensure compliance, but also stay attuned to the what's going on in terms of compliance efforts from CMS.
Absolutely, Kim. And are there any other takeaways that you'd like our listeners to bundle up and take back to their organizations?
Absolutely. I mean, as we say, probably with each podcast, analyze your financial and operational impact related to these payment updates, not just in the rates, but also impact for value-based purchasing, outliers, the LUPA changes, as well as any case mix weight changes. And again, utilize external experts in consulting this analysis if you don't have that ability internally, and update your policies and processes specifically regarding any regulatory changes and process changes and ensure compliance with face-to-face encounter and OASIS data collection and submission requirements. And then I would just say, as we also remind everyone, stay tuned for updates, certainly from us at CHAP, but really importantly from your state and national associations, and other experts in the field for ongoing education, and stay vigilant regarding any changes because, as you had pointed, we talked before, Jennifer, about, this is the home health final rule.
Right.
And there may be a way to sort of breathe a little easy because we went from a potential 6.4% to 1.3%, but MedPAC is also, recommending, higher percentage decreases or rate cuts, which is again a separate entity from CMS, but they're advisory. And so we really have to stay vigilant to regulatory and payment proposed changes, but also ensuring that our operations are as refined as possible, streamlined, to be able to ensure that you're able to meet those challenges.
Yeah, absolutely. It's always the hope for the best, plan for the worst every year when we're in rulemaking, essentially. I just wanted to add to your takeaways. We did present and post two very detailed summaries with the highlights of the home health content as well as the DME content on our website. And even though it's nice to listen to Kim and I talk about some of those highlights, you have to read. I know it's a bummer, but you have to read, whether it be our summaries, whether it be the CMS wrap-up summary, or if you want to choose a nice heavy red wine and dive into 762 pages of a final rule, there's no getting around at least reading something in terms of relatedness to the provisions in this rule. So hopefully we have helped you by doing the cutout summaries and hopefully getting you on your way to being compliant by January 1, 2026. Anything else before we bid our listeners adieu, Kim?
No, I think that there certainly is plenty for providers to be looking at. Specifically as it relates to home health, not just from the final rule, but also our industry changes and challenges. So, certainly, we appreciate everyone taking the time to listen to us, and we're happy to support you, with additional information, specifically as it relates to regulatory requirements, as we are also updated. So thank you. Thanks, Jennifer, as always, for inviting me to join you. And, and it's my pleasure.
Well, thanks so much, Kim. So from Kim, me, and the entire CHAP staff, keep your quality needles surging forward, stay safe and well, and thanks for all you do.